second speaker is Professor Dr. Hisham Hosni, Assistant Professor of Anesthesia and SACU, Faculty of Medicine, Cairo University. He's also Senior Clinical Fellow, Department of Anesthesia and ICU, Hartfield Hospital, United Kingdom. تفضل دكتور هشام.
Good morning, everybody. It's a great and overwhelming pleasure to be here today among my professors, my friends, my colleagues. I really want to thank the organizing committee and all the committee responsible about organizing this event for this prestigious and event. To start with, my talk today will be about introducing the audit or the culture of audit in our medical practice, and is it the gap filler? So, one of the most important sentences in the British railway system is to mind the gap. But to mind the gap, first of all, we need to see the gap. Do we really have the ability or have the tool or have the gadget that makes us as a clinicians to see the gap between what we're doing or what we should doing? So audit, in definition, it's a quality improvement process at the beginning. It aims at improved patient care and outcome through review of our practice against explicit criteria and implementation of change. What does it mean? In English, it means only just what we're doing compared to what we should be doing. This is what audit is meant to be. We all know what we should do. We all have long list of procedures, of guidelines. We all, coming from an academic and university backgrounds, we simply like it. We love it. But do we really, in our real daily practice, follow that or not? Do we believe in that? That's the problem. So, to start with, what can we audit? Simply everything can be audited. Every single procedure that we do, every single element in the trip of the patient from entering the hospital until going home could be audited. We can audit the structure as how many emergency theaters that we have over 24 hours. We can audit a process that we are doing, like the ventilated bundles or the long list of bundles that we have everywhere. Or we can audit our outcome of our clinical practice, and does it really successful or not, or does it meet the standard or not. Even we can audit how much time we need from presenting the speaker until the presentation really works. What size of audit can we do? Anything can be audited again. We can have a large national audit. An example of that is an audit which is running now in the UK about the incidence of complications after using transesophageal echocardiography in cardiac theaters and ITUs. This is a national audit on at the scale of the whole UK. It's a good thing at the project, but on the other hand, it needs a lot of devotion. Another audit that was done a few years ago about the ICU over nations audit, talking about the burdens in surgical ITUs, another international worldwide audit. But we can still have small departmental audits that we can do in our daily practice. Audits that we shared in the past few months, like acute post-operative pain in cardiothoracic surgery. So we measured pain. We measured patient satisfaction towards the degree of pain in the second day of post-operative and 30 days post-surgery. And according to their feedback, we came up with modification of our guidelines. Another audit is running at the moment is the compliance of lung protective ventilation ITUs. Everybody in this room, of course, loves lung protective and loves the 6 mils per kilogram of ventilation. But do we really do it? And how frequent? And do we revise it? This is what we are aiming for, the audit. So how to choose a topic? Audits are very interesting. That means you can still audit how much parking lots do you have in your hospital. But think of something which is risky. Think of something which could improve that risk that the patients might suffer. Think of something about the process that you're already doing every day, like transfusions. And of course, all my friends in the cardiothoracic theater know exactly how much blood do we use. Do we really need that much or not? You can audit your ideas about improving that, and how much waste do we have in our resources and manpower. So, to make it effective, think of something realistic. And in that perspective, again, I'll refer to my colleagues in the cardiac unit and the cardiothoracic unit in Cairo University, and where the problem was how to increase our number of cases done by every month. And the very first solution was convince our anesthetist to do a second round. I don't think that was realistic. But why was it? Because simply, they didn't have the political support. Nobody wants to do that. They don't have the muscle to do that. And this wasn't done. And the other thing is, they never thought about the resources, the ITU slots, anything which is ready under the control. So be realistic in what you're trying to audit. Examine the area of practice where you really have influence on, and then search for a frequent or significant issue, and then try to convince your colleagues to do it. If you succeed to convince your colleagues to do an audit, so this most probably will be completed, and most probably this is an important one. So to do an audit, what shall we have? First of all, we should have a goal, what to audit. And then we need a number of patients and need a time frame for the audit to run. The number of patients is very important, because if you are studying, for example, documentation, which is a real problem in our practice, I don't think that more than 10 patients will be very much enough to prove that we are lacking that at the moment. Or if we are trying to look for something which has a procedure, then we need a bigger number of doing that. And then we'll do pre-study surveys to know exactly, do the people involved in this practice know about the guidelines and know what they should do? And then we collect data and do the teaching for those involved, and then recollect the data after the teaching, and finally do re-audit time. This can be incorporated into a cycle, which is called the audit cycle. When you have a topic, we set the standard, we collect the data, we analyze the data, and then we implement the change, and then re-audit, and the cycle continues. So, if this is the ideal world, what do we have really in Cairo University? Do we need really to introduce this culture or not? These are the Faculty of Medicine training plan from 2014 to 2017, published by our university. And here we have it in the middle. It's already in our practice. So all what we need is just to read it. What we need to have an audit is just to do it. It's nothing more. Just to believe in it, just believe that this is something which will improve our practice, will upgrade our standards, and that's all what we need. Thank you very much.